Well, good morning, everyone. Thank you for joining our Grand Rounds here in first pediatric Grand Rounds of the 2026 calendar year. It's my pleasure this morning to introduce Dr. Derek Neilson. Dr. Neilson's been the Division Chief of Genetics and Metabolism for over 7 years now here at Phoenix Children's. He went to medical school at Oregon Health Sciences University, and then after that did a combined pediatrics and genetic residency at Rainbow Baby and Children's Hospital in Cleveland, Ohio. Following that, he was faculty at Cincinnati Children's for nearly 10 years. He's had gene discovery research programs for acute necrotizing encephalopathy, neurologic disorders, and also hypermobility and connective tissue disorders. He's developed a genetics residency program here at Phoenix Children's with the hope of expanding genetics resources throughout the state of Arizona, which we all know are sorely in need. And the title of his talk this morning is going to be Updates on the Genetic Evaluation of Intellectual Disability, which is going to be very important for all of us general pediatricians. And so without further ado, here's Dr. Neilson.
Thank you very much and good morning. And thank you, Dr. Hartley, for inviting me to give Grand Rounds this morning. And thank you very much to Ozzy for being so very patient with my information coming in. Okay, so we're going to talk about updates in genetic evaluation of intellectual disability. And just to start, I have no financial disclosures. Today, what we're going to be talking about are the current genetic testing modalities. I'm going to review the 2025 AAP guidelines for genetic evaluation of intellectual disability. And we're going to consider Arizona's current healthcare environment and how it affects genetic testing. To boil that down into simpler questions, we're going to look at what's changed, what are the new AAP guidelines, and can pediatricians order genomes now? And that was the question that Dr. Hartley asked me to address in this whole lecture. So the first question is, what has changed? So there have been a lot of changes in the genetic testing modalities over the years. This all started with the Human Genome Project, which the first draft of it was released in 2001. But it actually took another 20 years for it to finally be finished out. So that 90% was released in 2001, and it took another 20 years to get that last 10%. Turns out there's a lot of repetitive sequence in the genome that had to be resolved, and it's very difficult to do. But once the architecture had been figured out, that allowed the development of new technologies that rapidly changed the genomic landscape and our understanding of it. The big inflection point for our testing was really around 2010. Prior to this, our main tools were karyotype, which is more of a broad-based test where we're just looking at the chromosomes globally. It's sort of a more agnostic test versus the more hypothesis-driven tests such as FISH or single-gene PCR and Fragile X testing, which were our main tools prior to that. Karyotyping is actually a physical and visual test where we're actually looking at the chromosomes under a microscope, counting them all up, and then somebody has to count up all the tiny little bands to figure out if they're all there or if there's any missing there or that are added. Very highly specialized test. People have to be very well trained to be able to recognize those tiny little changes. The other test that we were using quite frequently is FISH. This is fluorescent in situ hybridization. And what we're doing is we're putting our chromosomes onto glass, and then we're adding a fluorescent probe on top of it. Those little probes really only go to one area. So a FISH test only looks at one or two things because you can only get a few colors on a slide at a time. In this particular slide, what we're looking at is all of our chromosomes are labeled in blue, and we have two little green probes here showing which of those little blue blobs are actually chromosome number 22. There's a test probe which comes out as red, and you can see it here binding to that chromosome 22, so that one's normal. But this one does not have a 22 probe bound to it, and this is an example of deletion 22 syndrome. Our other test was for Fragile X, and that is a test of the triplet repeat that is associated with Fragile X syndrome. What we know is that this was recognizable by some of the findings, such as macrocephaly, protruding ears, macroorchidism, and intellectual disability. What we know is that that large CGG expansion, which once it gets up to 200 repeats or more, can actually shut down the neighboring gene, which is FMR1. And this is an X-linked disorder where boys tend to be more affected than girls, but this test is actually indicated for intellectual disability of both boys and girls. So after 2010, we had a lot of changes. And this slide is just to remind myself that sometimes things happen very fast. So if you're on a hike when it's nice and sunny out, suddenly clouds can come rolling in and we're running back to the car in the lightning storm. This is up in Sedona. So chromosomal microarray came into clinical use around 2008 and quickly replaced karyotyping. Whole exome sequencing was first published, the first studies were published in 2008, and then it became clinically available in 2010. And clinical usage of both of those tests rapidly accelerated, and the identification of genes began to happen very quickly. So we'll just take a quick look at chromosomal microarray. This is a technique for looking at the chromosomes and seeing if there are small pieces that are added or missing that are too small to be seen under a microscope. The first microarrays were sort of a flip of the FISH process. So instead of putting the chromosomes on a slide and then adding color to them, you would actually add the probes onto a slide and then add the patient DNA on top of it. But in order to get a difference, you would have to actually spike it with normal DNA to create a difference. So what we do is label our patient DNA in one color, in this case green, and the control DNA in a different one, red. When you mix them together at equal amounts and add them to the probe, if they are equal, if they're present in equal amounts, they will create a yellow color. If one is represented more than the other, you're going to see a difference. So here we can see that there's a green color coming out for this particular probe, meaning at the location of that probe in the genome, there's more patient DNA than control DNA, and that would suggest a duplication. Conversely, if we're seeing red, there's more control DNA than patient DNA, or rather there's less patient DNA, which would indicate a deletion. And so this is a very small representation of that process. We would typically use thousands of probes spread out across the entire genome. So that was how it started. But there were additional techniques that rapidly eclipsed that. So what we're doing now are oligonucleotide arrays. What we're doing is taking probes, or we're doing sequencing reactions for single base pair polymorphisms within the genome. And we are doing millions of them, approximately 4 million to be exact. And what we're doing is we're taking our DNA, shredding it up, and adding it to these little probes. And these are, in this particular scheme, these are all represented as beads. And so we have a tiny little probe sequence that is designed to attract a very specific piece of DNA. And then we just do a single base pair extension on that probe that will actually create a colorimetric light-producing reaction. And so in this case, what we can see is because the sequence had a C in 2 copies, it glows green. Here, there's a C and an A. These are labeled green and red, so together they're giving a yellow color. And 2 A's together here is giving a red color. Obviously, you had to add 2 more colors to get the T and the G in there as well. But what this allows us to do is at any point, do a genotyping reaction to say, do we have an A, a T, a C, or a G? And so a microarray in this form, we're using known polymorphisms spread across the length of the genome to be able to do genotyping reactions at each position. What we do with that is we can look at 2 different pieces of information. One is we can look at the total amount of light being produced per position, and that is given as a relative signal intensity. So if there are 2 copies of the chromosomes, we're going to kind of see this middle line. And then we can also see, what alleles do we have that are present? And these are going to be randomly distributed versus the major allele and the minor allele, the one that's more normal versus the one that's the less common one. And we can look at the homozygous major allele, the heterozygous allele, or the homozygous minor allele. And all of these will be creating signal as well. So as we move down the length of the chromosome, we can see that we're seeing lots of heterozygosity along the length of this chromosome. And then suddenly it goes away. And we're only getting either the major allele or the minor allele. And in this case, we're also seeing that the signal intensity drops. And this tells us that the reason that we've lost our heterozygous allele is that we've lost one portion of the chromosome. Everything here is actually missing, which is why our signal is lower and we don't see heterozygous signals anymore. So this is a much finer resolution test. A microarray can actually detect deletions and duplications of around 25 to 50,000 bases. That to us is very small. Previously, if we're looking at our chromosomes under the microscope, a band like this, our limits of resolution are about 4 to 5 million bases. So this is an improvement of about 100-fold. We can see changes 100-fold smaller than what we can see with our naked eye through a microscope. And this is just kind of giving you a very similar look of here's our normal signal, and we have suddenly a drop in signal intensity in this direction, showing that there is a small deletion on this chromosome 1. So these oligoarrays are using known variations in the genome to help capture and identify the target sequence. These are the tests that you're going to be seeing used in private companies like 23andMe and Ancestry.com. They're using millions of probes per chip. We can see copy number variants, such as deletions and duplications. And it can also give us areas of homozygosity. That's kind of interesting because this can give us some degree of estimate of relatedness between parents. If we just see a small section of one chromosome, it may be that they're just sort of related at a population level, like they came from the same area of Europe, for example. However, if we have multiple areas of homozygosity existing on multiple chromosomes, that could suggest that parents are more related to each other. Sometimes this is because they are directly related to each other, such as being cousins. Sometimes this is actually because of population bottleneck situations. So it is very common for us to see this kind of situation coming from patients who are of Navajo origin or coming from small towns in Mexico. So when we're looking at these oligoarrays, we have to understand that this is looking at the content. We're not actually reading the genes. And so this is sort of like taking a book and counting up all the pages to see if all the pages are there. One of the limits is that oligoarrays cannot identify structural rearrangement. So as much as people have been saying sooner or later karyotypes are going to go away, they never have, because nothing has been able to replace the idea that we sometimes just need to look at them to see if one piece of DNA is not where it's supposed to be. So our other technique is whole exome sequencing, and that's where we're reading all of the instructions all at the same time. And this is a highly technical process that looks a lot like this. You take your pages of your instructions, you shred them, you pull out the pieces that you want, and then you read them and reassemble it just like the FBI does with your garbage. Okay, so if that looks too simplistic, here's an industry slide. You take your DNA, you shred it up into tiny little pieces, you pull out the ones that you want, and then you throw it onto a machine that reads and understands it for you. This process here, this is the real technique of the exome, which is we're trying to pull out little fragments of DNA that correspond to the known genes. So on this particular chip are probes that are designed to capture pieces of DNA corresponding to every known gene that we have. And the reason that we do this is that we can wash away everything else, and that simplifies the amount of information that we have to process by a factor of 100. This was very important 10 years ago when we had less available computing power and less available sequencing power. It was very hard to sequence everything at once. However, if you want to do whole genome sequencing, you just do this. Skip that step. You shred everything, you throw it onto your machine, and you sequence everything. And so the machines and processing are much faster now, to the point that it is much faster to do a whole genome than it is to do an exome, mostly because you get to skip a step now. There are lots of techniques and lots of different companies and processes. They will vary by read length and accuracy. Old school was 99.9% accurate. The newer stuff that we're using will give you reads of about 75 to 100 bases, or even up to 400 to 600 bases at a time. So they're fairly short, but they're highly accurate. Other machines can give you really long reads, 10 to 15,000, and that's really helpful if we're trying to untangle a complicated area that has a lot of repetitive sequence, or if you actually want to sequence through the Fragile X gene, you can do it with these kind of machines. Not so easily, but you can do it. The downside is that it does have random errors of about 5 to 15%. We don't like that. Then they say, but if you do it a lot, you kind of average out the errors. Still not very comfortable. So these have not caught on in the same way that the short read sequencing has caught on. But we may see some shifts on that in the future. I added a few slides or a few images just to show you what the sequencing looks like. It's kind of interesting. And I realized just the other day that it was very hard early on to get a good idea of what these companies were actually doing inside the machines. The previous slide where they would show you what the exome process looked like always just kind of ended with it, and you put it into the box, but they didn't want to tell you what was in the box. And that was because there was a lot of competition going on and nobody really wanted to share what exactly they were doing. So this is one technique, and you can see that the commonalities between these two is that first you actually shred everything into tiny little fragments, and then you try and isolate it down until you're amplifying single fragments at a time. This particular strategy attaches it all to a bead where all of these, everything stuck to that bead is actually a copy of a single strand of DNA. These beads are then put into these little chambers, and they add sequentially nucleotides. And each time they do that, it has a special chemical in there that will cause a flash of light if that particular nucleotide is incorporated. So they keep doing cycles of that and measuring which ones give them flashes of light in order to see the sequence. This version uses a solid state sequencing where you're actually putting strands of DNA onto these little linkers, and those little linkers, that DNA is actually going to kind of stretch over and make a bridge so that you're amplifying from point to point on this slide, kind of like watching a slinky go down the stairs. But each time it goes down the stair, it makes a clone of itself. And then that one goes down this, and so we see these sequential cloning reactions of itself. This will actually make a series of these sort of bridge molecules all in a constrained area on a slide. And then what they'll do is they'll actually go and take a photograph of that, and they'll watch that little area change colors as they add new nucleotides to it. So they'll take sequential digital images to make it the DNA sequence come out. So all very fascinating stuff, but it is all sort of in the box. It is not very interesting to go into genetics labs anymore, because it all is like we take it from this box and we put it into that box. What do we get? We get the output of these machines is to give you these fragments of a single fragment of DNA. And what they'll do is align this to the genome. So that's why we had to have the entire sequence, is because we had to know where all these fragments actually were supposed to go. And then what we'll do is see all of these are highly homologous to the sequence, except for this little spot right here, where instead of a C, it's a T. And so that gives us one of our variants of our genome. And so this is homozygosity for T, except for right here where there was a sequencing error and it came out as an A. So yes, these things do occur. Our readout is going to be not all of these fragments. We're just going to get a list of everything that is a variant, everything that is different than the reference sequence. What is the magnitude of that? For anybody that we do this for, if we're doing exome sequencing, we get 24 to 25,000 variants per exome. And so there's a lot of stuff that a person has to go through to kind of figure out, okay, which of these variants is actually causing this person's disorder. The interesting developments that came out in 2008 was the concept of trio sequencing. In this scheme, the idea is that you look at your patient, the proband, and you compare that person to their parents. And you look to see for anything that you find for your patient, was that inherited or not? And what you can look for is anything that the child has that did not come from the parents. Those are going to be brand new changes. And for any of us, there's around 2 to 5 brand new genetic changes by this method. And what they were able to do is show for this particular patient, there were 2 genetic changes. And for this particular patient, there were 2 genetic changes. And for each patient, there was a change in a gene that was common between them. And this is how they figured out Kabuki syndrome. Kabuki syndrome is a disorder of, it's a neurodevelopmental disorder that has specific facial findings, growth characteristics, heart defects. And what they were able to show is all of these children had genetic changes in the same gene. And none of those children had inherited that from their parents. All of them had it as a brand new change. So this is the new era of de novo inheritance, meaning brand new changes that are not inherited. And this explains something that had been a real problem for us, which is that we would find patients with Kabuki syndrome, but they never had siblings or cousins or anybody related to them that had the same disorder. It was always sort of something that was brand new. And because the children did not tend to grow up to have families of their own, you never saw it being inherited. So we just couldn't figure out why it was happening until this. This basically meant that after this, everybody and their pet dog got into sequencing trios. And that meant there were huge projects where they would just say, let's take everybody in our clinic and do trios on everybody. And that meant there was a huge boom in gene sequencing and gene discovery. So this is a graph, and unfortunately, this one was published in 2021, so it only goes up to data from 2018, but it showed the number of genetic factors that were found over that period of time by exome and microarray, and they found up to 3,000 new causes for neurodevelopmental disorders. Before that, we were sort of down here at, maybe 50. In 1998, maybe less than that, and we went all the way up to 3,000, with 2,200 of those being over a 10-year span. And in the later half of this decade, there are approximately 300 new conditions being identified per year. Probably that continued out a little bit longer, and it seems like this is probably tapering off, but nobody's updated this kind of study to let us know where we are at this point. But this meant there was a lot figured out very fast. So with this new information, we have some new guidelines. And so what are those? Well, before I jump into that, I just want to make sure we go through a few definitions. Intellectual disability, of course, its limitations has a number of factors that go into it. And I put this up here to remind myself that all of this is a little bit fuzzy. But first, we need to have some sort of limits in learning and reasoning. This is generally identified by an IQ test showing scores below the second standard deviation. These are scores of somewhere in the 70 to 75 range. There's also limitations in adaptive function, and these have to do with conceptual, social, and practical aspects. So conceptual are things like understanding what time is. Social is the interpersonal skills. Practical is more like, can you navigate our society? Can you manage money or travel across town? And all of this has to occur in the developmental window, which is variably reported as up to 18 or 22 years, depending on your source. As I said, there's some fuzziness in these definitions. Compare that to global developmental delay. And we often use global developmental delay even up into older ages, but it's actually more properly used when we're thinking about the younger kids, when they're not actually old enough to undergo the more formal diagnostic testing. And so what we're looking at are delays in the attainment of milestones, looking at motor, speech, social, and cognition. So when we're looking at studies of global developmental delay versus intellectual disability, we have to kind of keep these processes in mind, because there are some kids with global developmental delay who do catch up. I've seen that. It's always sort of surprising because I'm a referral pup, I have a referral practice, so that's usually not my view, but so it may happen more than I recognize it happening. And then also just the term neurodevelopmental disorder. This is a term that gets loosely applied across genetic studies, and that can include intellectual disability, global developmental delay, but it also can include autism, epilepsy, and syndromic and multisystemic disorders. And studies are not always very good at really defining how they included or excluded patients in their populations. They just kind of like to tell you what they found. So for any given study, the diagnostic yields and interpretation are going to vary based on what kind of stringency they used in putting their study together. That kind of helps explain this, which is a 2019 meta-analysis of whole exome sequencing studies. And here you can see there's sort of a midline or a average line of 36% going down here. And you can see that the study yields were up to 90% in one study, although it only looked at 10 kids. Versus this one that looked at 1,700, which had something that closer to 30%, and even lower than that, sometimes only 8%. So looking at all these together, the average across all these studies is that whole exome sequencing can solve the cause of a child's neurodevelopmental disorder about 36% of the time. So the diagnostic yields that we typically use when thinking about this are for Fragile X, that testing yields a result in about 0.5 to 1% of cases. Chromosomal microarray, 10%. And whole exome sequencing, 35%. And so when you look at the yields on that, you begin to say, well, which one should we choose first? And that explains why we had some a shift in our recommendations from the American College of Medical Genetics. In 2010, the recommendation was that we should do Fragile X and microarray for patients with intellectual disability and autism, along with selected gene testing. Now, basically, they were saying selected gene testing, if they had a large head, you should look at P10. If they had regression, you should look at NECP2, and the recommendation stopped. And just about everybody said, forget that. And we were doing big panels and went to exomes much faster than that. So in 2021, after the meta-analysis was done and we had a lot more data, that's when the recommendation came out that whole exome sequencing or whole genome sequencing should be considered a first-line evaluation in the evaluation of intellectual disability, global developmental delay, or multiple congenital anomalies. It didn't necessarily say, however, what we should do first. Should we do a microarray first in Fragile X like we used to and then do whole exome? Or should we actually do whole genome or whole exome first? So it kind of left a little bit of fuzziness in that recommendation. It just said we should consider these as part of the first line, not necessarily the first line. And also notice what is missing from 2021 recommendations. Autism is no longer there. It was there here, but this is no longer present. Why? It's because the diagnostic yields that we're getting really depend on the diagnosis of global developmental delay or intellectual disability. So this was a paper from Brown University looking at patients that had autism with or without intellectual disability, and they looked at 523 subjects. Overall, they had a yield of approximately 15% for their study with exome. However, when they split that out based on does that patient have global developmental delay or not, if they did, their yield actually increased to 16.8, and the yield without global developmental delay dropped to 2%. And that tells you that really the driving factor here was the intellectual disability, not the autism. So this is not necessarily the best test for our cases that may have milder autism that are well functioning but have social delays. So shortly after the ACMG guidelines were changed, we have a change in the AAP guidelines as well. Now, this is a little bit hard to see on the small screens. So I am going to flip forward to the next slide to show this a little bit better. Basically, what we're looking at is in 2013, the order of questions were, is there a recognizable syndrome when you look at this child? If yes, test that syndrome, whether this is karyotype or microarray based for deletion 0.2 or sequencing based. If you're not able to recognize a syndrome, then do a chromosome microarray plus Fragile X. If you're not able to come up with anything on that, then do phenotyping. Phenotyping might be metabolic testing, X-linked panels or RET testing, or more phenotyping like MRIs or get additional consults at that point. The new set of guidelines says, first, is there regression? If so, refer. And the referral could go to neurology or genetics. Second, is there a recognizable syndrome? If yes, test. So choose the most appropriate test. Like you can, if you're seeing something that looks like Noonan syndrome, you can do a Noonan syndrome panel or something like that. And if you're not able to come up with a recognizable syndrome, or you're not getting anything off this test, then proceed with agnostic testing, meaning we don't really know what it is and we're just going to look at everything. And this, first on their list is whole genome sequencing. Second on their list is, alternatively, whole exome sequencing plus microarray. Now, why do we split those? Because whole genome sequencing can give you both sequence data and copy number variant data in the same test. To do that more accurately with the exome, you also have to have a microarray. So those two tests can actually be done just with a single genome, and we don't have to do two afterwards. But basically what you see is for many of our patients, they are non-syndromic. And so we're going to just bypass those first two steps and go straight to whole genome sequence. If that is normal, then do phenotyping and then do Fragile X, which is completely backwards than what we used to do. Now, just a word on that real quick. Who would we actually want to do metabolic testing on? Well, from the guidelines, it's patients with regression, neurologic signs like epilepsy, spasticity, movement disorders, multi-system involvement, abnormal body odor, any kind of biochemical abnormalities, abnormal MRIs that might be suggestive. The diagnostic yield of this, however, is around 1 to 5% in patients with undifferentiated intellectual disability. So that's why it's lower on the list. And what we're really trying to do at that point is, if we have a negative genomic study, we're really just trying to catch up to say, is there anything else that the genome might have missed? These are not infallible tests. They are usually designed to pick up somewhere between 95 to 99% of all variants. And because most of these are going to be recessive disorders, hopefully you'd catch at least one of the alleles. But most of the time we actually can find the inborn errors of metabolism on this. So that's why genome is actually preferred instead of doing the biochemical testing first. Also, some of our patients could be mild and they may only have intermittent biochemical changes. What other things should we be doing? Hearing and vision for everybody. So to me, this is both diagnostic and therapeutic, because if a child is not developing well and they can't tell you that they can't hear very well, you're just going to have to go look. That would be a barrier to that child learning, even if it's not part of the primary disorder. And then MRI would be indicated if there is an abnormal head circumference, focal neurologic signs, seizures, increased tone, or regression. So now we get to Dr. Hartley's question. Can pediatricians order genomes now? And so we have to kind of look at what is the state of medicine, especially here in Arizona. So I would say that this is a matter of perspective. And these are my kids at the Museum of Illusions in Scottsdale. That's kind of a fun place to go. And all of it's all about perspective. So considerations for pediatricians ordering genomes or genetic testing. So technically, this statement says pediatricians can order genetic testing, but there are other barriers and requirements that we need to keep in mind if you choose to incorporate this into your practice. First of all, is insurance limitations. That's really the biggest one. And then there are a couple of things that we really need to learn how to do well. One is genetic consent, and the other is interpretation and follow-up. So this is the big barrier, which is insurance. Insurance policies on exome and genome. This is sort of an average between a number of insurance companies reviewed. I didn't want to call any one of them out, but they typically say things like, this is a medically necessary test if the patient has been seen in genetics. meaning if they've been seen by a clinical geneticist or a genetic counselor plus a specialist. So it's usually like if it's been seen by a neurologist or a developmental pediatrician are the most common. So this, I would say, is probably the biggest barrier. It is possible to bypass this if the parents want to pay for themselves. You do get a reduced rate compared to the insurance rate, but you're still talking about a few $1,000s. The other requirements from insurance is that there is a perceived potential change in management and clinical outcome for the proband. That means we're not doing it for family counseling reasons. We're actually trying to help the child some way. And that there's also one of the other following criteria. Other genetic testing is negative, but we still suspect a genetic diagnosis, or we're trying to avoid an invasive test. And I will tell you that, before all this testing, we used to do things like muscle biopsy all the time, and now I hardly ever do that because we can usually get the information in other ways. So avoiding some of the invasive tests can be helpful. And also that simpler and more direct testing is not available. I'll get to that point in just a minute. Some policies will say you can do a genome only if you haven't done an exome, meaning we're not paying for both. You get one or the other. And some companies also will exclude all genetic testing, so that is still out there. There are a few trends that have come about as well. So sometimes we are looking to say, hey, we have a condition and it just has, it's caused by 10 genes listed to a panel. And some insurance companies are saying, we know that you're going to do an exome if your panel is negative, so just do the exome, stop doing panels. So some insurance companies don't pay for panels, but will pay for exome. Likewise, some of the labs have gone away from offering panels, and now they're just doing exomes instead, and they're really limiting the amount of choices that you have. This has also coincided with that fact that we rarely get pushback on doing exomes these days. There still could be very high out-of-pocket costs. So you do have to warn people, like if they're on a high deductible plan, you're going to see the full price of that exome, and it's going to look scary. Your deductible will be gone in one test. So people think, well, I've got good insurance, it'll pay. But yeah, you're going to pay a lot. Or you have to be able to be prepared. Moving on to the concept of consent. There are a few laws that we have to kind of take into account as we think about this. First of all, Arizona state law requires specific written consent by the patient being tested or by their legal guardian. So you must document your consent process. They actually have a whole webpage on the state website that showed everything that you needed to talk about. And interestingly, when I went to go find it, while in preparation, it's no longer there. So I don't know exactly what they're expecting anymore, but the standards of consent from the field are basically that you need to talk about a few things. First, it's a voluntary test, that we're not going to be, denying them healthcare if you don't do the genetic testing. Second is that there are a few risks. One, basically of accidental disclosure of things that maybe people didn't want to have known, such as there may be non-paternity. Since we're doing trio testing and we're incorporating both parents, we can tell if dad's markers don't match the child's at all. Also, you can find out things like consanguinity, meaning the relatedness of parents. So we can tell if patients are cousins. We can sometimes see that patients there may be evidence of incest, and sometimes those have legal implications. So those are things that people need to know about ahead of time. Also, there is a risk to insurance. It's a theoretic risk, of course. I've not necessarily heard of denials happening because of this, but it's out there. The idea is out there. The idea is that health insurance is actually protected. So there's the Genetic Information Non-Discrimination Act. So you cannot lose healthcare, you cannot be denied healthcare, and your insurance rates cannot be conditioned on your genetic testing. In fact, they can't even ask for your genetic testing. However, this protection does not apply to disability insurance, and it does not apply to life insurance. So sometimes parents will opt to not test right away so that they have the option to get a few quotes on life insurance for their child before they actually move forward with any testing. There are a few other state laws on genetics. One is this has to do with the confidentiality and privileged information. It's sort of Arizona's version of the sort of a combination of GINA and HIPAA for genetic testing, and it basically specifies who is allowed to access genetic information and under what circumstances. It's kind of a long list, so I didn't go into the whole thing, but it's usually like, okay, yes, the patient, the physician, the people taking care of them, and then various state agencies and regulators that might need to look at this on sort of a population study level. It also has a law on direct-to-consumer testing. This one's kind of interesting because it kind of talks about how the companies need to post very clearly what their policies are on data sharing, including selling your information to marketing companies. It also specifies under what circumstances law enforcement can engage with those particular companies, which is kind of related to that process by which, the Green River Killer was identified through DNA through these genetic testing companies. This kind of blocks that unless you have direct warrants. They're not allowed to just cooperate freely if you don't have a warrant. The other thing that we have to take into consideration is once we have that result, what are patients going to hear and what are they going to do? Because in many cases, what will happen is that we'll see that a patient had testing, and then we get something that is a variant of uncertain significance. And then they're told, oh, go see genetics and they'll explain it to you. Okay, so a variant of uncertain significance is a situation in which we have a finding, and the lab has deemed that it's somewhat interesting. Maybe this is an issue, but they can't resolve it further based on the available data. So what we have to do is then correlate that finding to the patient. Does this gene actually match what we see with the patient? Sometimes it requires further testing of family members if we didn't do the trio and we need to test the parents. And sometimes it's resolved later on through research-based modeling and things like that. And it's very common. So in a study of they reviewed about 1.6 million individuals and their genetic testing, and 41% of them had a VUS. Over time, 7.3% of those were reclassified. 80% of those that were not understood before 80% were later reclassified as being benign and non-causative. But 20% were then classified as being likely pathogenic or pathogenic. So that just tells you that this is truly we don't exactly know, and we're just waiting for that additional information to help us understand what this actually is. You're more likely to get VUSs with more genes. The more genes you test, the more likely you're going to find one of these things. And this is also more likely to happen in populations who are underrepresented in databases. This is extremely relevant to Arizona because patients who are Mexican do not tend to be represented in the global databases as well. So we find a lot of things where we're like, yeah, I know that, the more common thing is that they really just resolve as everybody in the family has it and they're all fine. And it's just an issue of who was part of those control populations. Problem is if you say, okay, here's what we're seeing, and we really don't know, and now you have a 9 to 12 month lag time to see a geneticist, who are we going to be seeing in the meantime? Well, Dr. Google's out. It's Dr. ChatGPT now. And so what we're going to see is we often get patients coming in who have spent that entire intervening time looking things up on the internet. And they will come in with very strong belief structures in either direction. Some are convinced that the VUS is causative, when it may not be. Some are convinced that it's actually just fine and we got to do something else, when in fact that was actually the causative factor the entire time. And so we end up having to do a lot of backpedaling and trying to help people understand what this is really all about. And so this, I think, is one of the challenges that we face when we don't have good resources to understand what these VUSs are all about. So in summary, genome sequencing is available to pediatricians, but pediatricians who order that genetic testing will need to, one, help patients navigate their insurance requirements, provide appropriate pre-testing consent, and interpret the results and provide perspective. Even if you don't understand everything, at least be able to help guide them that, well, stay off of Google. I think the worst one was, a patient coming in that was highly convinced that their child had trisomy 13. When we finally got the result, when they finally came in and showed us what they had, it was actually a small duplication on chromosome 13 that did not involve any genes. So it actually wasn't seeming to do anything at all. And we ended up having to do additional testing to kind of figure it out. But during that entire period of time, she was really convinced that her child was going to be dying of trisomy 13. Okay. So in conclusion, genetic testing has made significant strides in the diagnosis of neurodevelopmental disorders. Whole genome sequencing is now recommended as a potential first-line evaluation, especially in non-syndromic patients with developmental delay and intellectual disability. In many cases, the limitations for obtaining the tests are really about insurance and pre and post-test counseling, including understanding of VUSs, are going to be very important considerations for pediatricians who want to incorporate that into their practice. Questions? Go ahead.
This is the process for helping people with insurance. Like, do you just tell them all their insurance and see what's covered, or at what point in ordering the test do you figure out?
So there's a lot of steps that are involved. Often we have to kind of look and see, what is their actual policy. They can call, but I will tell you, like, it really feels like if a person calls their own company, they can call 3 times and get 3 different answers as to what's going to happen. So looking up the written policy is part of it to understand, does their child qualify according to those particular rules? Then you have to kind of figure out, will that, does that lab that you're interested in using, is it going to take that? Then we also have to kind of figure out, like, okay, what are we looking at in terms of the other parts that are often involved are how much is this person going to be out of pocket for that particular test? These do vary by lab. Some of the labs will actually do a lot of that for you. And so if you just so sometimes just sending in the test means that they'll do the whole pre-auth and they'll call the patients back and things like that. So that can be very helpful. It used to be that they would sort of say, send us the DNA and the order, we'll call and we'll just hold it if the parents don't tell us to go forward. Their policy on that one has flipped so that now they actually say, if we don't hear from the parents, we're moving forward. So sometimes the parents are now getting surprises on that. So there's a few different steps.
I presume whole genome is more expensive than whole exome. What's the difference?
It's hard to get exact pricing on these things. I don't want to speak out of turn. In general, the number of 5,000 to 6,000 sticks in my head for whole exome, and it's probably more like 8 to 10 on the whole genome. But the problem is that all of the labs participate in that same insurance game, where there's what it actually costs, and then there's what they're going to bill because they're not going to get that full thing, and because it's all going to get reduced. So that makes pricing discussions very difficult. But that gives you just sort of the scope. People that want to self-pay those tests may be on the order of 2,000.
Okay, that's a good answer. Okay, we have 3 questions here in the chat. First one, hi, I work with foster kids. What do you do for testing when parents are not available?
So that really becomes the legal representative on that one really becomes more commonly DCS. So we can do testing. So I guess there's two levels. One is, can we actually do it if a parent is not present? So we do have to have a legal guardian who is capable of signing off on that particular test and providing the consent for it. It would mean variably that we may or may not be able to include the parents in the genetic testing. Sometimes parents are simply unavailable. And we can do singleton testing, meaning just the proband. We tend to go lower in terms of we would choose panels or exome instead of genome, mostly because the more testing you get, the more variants you're going to get. And that means there's going to be a lot more things that are unresolvable because you can't compare it to the parents. So it becomes a lot harder to deal with when you don't have it. You can do it, but we try to be more targeted in our evaluation.
Okay. Another question. To refer a patient into genetics, we are being told they are being triaged. Can you explain what this means?
Okay, so the question is about what is the process of triage in genetics? So we're basically looking for patients where we would think, okay, this is a child that actually needs to be seen sooner. So as I mentioned, we have a 9 to 12-month waiting list, but there are certain circumstances where that may not be appropriate. So there may be children that have more serious diagnoses. For example, inborn error of metabolism, we want to get that child in very quickly because we're really trying to start therapy right away. We would want to we made some special inroads for surgical cases when we found out that kids were putting off surgical decisions with orthopedics for years because they hadn't seen genetics. So things that are where we want a timelier answer, what we're trying to do is make a road so that we can move people forward in the line. Everybody else is just going to go into the end of the line. I will tell you that the less information that we have, the more likely you're going to end up at the end of the line. So if somebody says, it is not uncommon that we'll just see the ICD-10 codes for the reason that a child was seen at the office. So if they were seen because of acute diarrhea, and that's the code that comes in, we are not putting that in the front of the line. So we will need a lot more information. So sometimes we do ask for more information so that we can understand, should we bring this child in sooner? That is the main role of triage.
Okay. We got a question, a comment from Dr. Friedman. I think he may be unmuted now. So Dr. Friedman, if you can hear me, go ahead. I'll let you ask it out loud.
Yeah, thanks. Thanks, Derek. Hopefully you can hear me okay. Great talk. I just wanted to address a couple of questions regarding the issue around ethical components to genetic testing, because I think that's one area that we may not do very well. You alluded to some of the questions about genetic consent, but could you also talk a little bit about, one, understanding the nature of the test, because that is involved in consenting a patient or family, and two, the actionable items that need to be reported, and then three, the opt-in, opt-out options, especially on genomic or whole genome or West testing, and that the provider doing the counseling really has to be aware of all of these additional factors to the ones you spoke about.
Thanks. I'm glad you brought that up because I realized that I spent way too much time looking for all the legal stuff and forgot about some of the other factors. So some of the other things to understand. I'm trying to decide what to go with first. So one is just understanding what genetic testing is all about. So it's important to recognize that the genetic testing gives you the why of things, as opposed to making diagnosis necessarily, especially because we often get patients coming in who say, we're trying to figure out if he has autism. Genetic testing doesn't tell you if you have autism or not. If you have autism, genetic testing will help you understand why it's there and maybe what we need to do in the future to help take care of it. Another aspect is the aspect of secondary findings. So when we test everything, we are really looking at everything. So we will look at all the genes, including the breast cancer genes, the colon cancer genes. You can find other conditions that are adult onset disorders. And you have to, and there's a list of genes that come from the ACMG that are required to be reported. And so those are some of the things like, breast cancer and colon cancer and things like that. And so when we do that test, what we have to help people understand is that these will be reported, but not everybody wants that information. And so parents have to make that decision before doing the testing of, do I want to know this or not? Because if we do that test and we find a genetic change in the child, then we can actually figure out which parent it actually came from. And we are required to help to disclose that information. So if parents don't want to know their own information, they have to make that choice up front. Otherwise, everything's kind of set into motion. Let's see, there was a related point that is now escaping me on that. The other other considerations are, looking for adult onset disorders. One is that we don't do genetic testing for children if the disorder is going to be onset in the adult stages. So if a parent comes in and says, I want breast cancer testing for my child because everybody in my family has it, we do not do that until the age of 18 when the child can make that decision for themselves. If, however, it is a gene that causes cancer early on, such as things like PTEN, we would do that testing because we want to start screening the thyroid right away, and especially very near the teenage years. One of the things that often gets talked about is, conditions like Huntington, which are neurodegenerative and occur over time with aging. And current exome technologies actually cannot figure out Huntington very well. But if we begin to see more of the long read sequencing, that could figure those kinds of things out. So we might be seeing different kind of recommendations coming out on that one. But I think most of the time we're trying to not report those kinds of things. It's sort of like newborn screening. You're only looking for the things that you can do something about on that list. So things that have no defined therapy or treatment are not in the reportable category.
One last question from Zoom and then we'll close it. Do we still consider mutations in epigenetics or not anymore?
Sorry. So the question is about mutations and epigenetics. So sorry, I'm thinking about, okay, so epigenetics, I don't often think of as a mutation, so I'm trying to figure out if that was one question or two questions. So the idea is, yes, we absolutely do. That really kind of comes into more of the targeted, if we recognize that this looks like a imprinted disorder, we would actually want to test for that more specifically. It may come up later under, once we've found nothing else, we may go looking for some of those epigenetic style disorders. But we definitely try to pull those out first on the phenotypic level to try and to make sure that we choose the most appropriate test if we're looking for Angelman or Prader-Willi or anything like that.
Thank you very much. Advance one more.
Oh, yeah.
Oops.